am very excited to present our final workshop speaker. Our final workshop is going to be given by Yuexing, who is a PhD student at Cornell University in human behavior design. So prior to graduate school, Yuexing earned both a bachelor's degree and a master's degree in computer science from Rutgers and Tufts University, respectively. She's won a variety of awards, including a meritorious prize in the interdisciplinary contest in modeling, ICM. She's won the Gary Marston Travel Award and a graduate student research competition at Tufts. So Yuexing's research focuses on health intelligence, computer human interaction, and VR/AR. I personally am very excited for this one. It features a hands-on component with sort of simulated case studies. And Yuexing's workshop is entitled Health Intelligence for the Future, Building AI-Infused Clinical Decision Support Systems. Please welcome Yuexing.
Hello, everyone. My name is Yuexing. Thank you so much, Laura, for introducing me. So I'm going to share my screen. So today I'm going to talk about health intelligence for future, building AI-infused clinical decision support system. First of all, I would like to thank for all the sponsors, Cayuga Medical Center, Women Entrepreneurship for SDM at Cornell, SIGCHI, Special Interest Group of Computer-Human Interaction, Health Design Innovations Lab, and it's also affiliated with Cornell Institute for Healthy Future, Human-Centered Design Department, and also Graduate School Career Beyond Academia. So before I start, I would like to introduce myself. Thank you, Laura, for introducing me. I would like to go a little bit further about my background. I have 2 computer science degrees from Rutgers and Tufts, and right now I focus on human-centered design. My area of focus is more on the health side, on the healthcare, on the clinics, on patients, on physicians, on the stakeholders. And here are some publications. Actually, right now I'm at CHI conference on human factors in computer system, which is happening in Hamburg. So hello from Hamburg. So before I start in today's topic, I would like to share a little bit table of contents for today. So for this whole around 50 minutes to 60 minutes, I will try to use the first 30 minutes to introduce the specific topics, like what is health intelligence? What do you mean by this kind of AI-infused clinical decision support system? And I'm going to use the 20 minutes to introduce about some hands-on activities, which will be really interesting. And then on the last 10 minutes, we will do a Q&A session. So welcome any questions. If you have any question, please type in the chat. Also, please let Laura know if you have any specific. So I would like to start today's workshop from a theme map. I would like everyone to think about you're building a wedding cake. You know, wedding cake is usually considered huge and big. So before building a wedding cake, you have to do some design. So this is really similar to my research because my research focused on a foundation, the framework, which is called human-centered design framework. So that's the foundation for the wedding cake. I built on most of my research. Currently, I will say all of my research on human-centered design, which means we will think about the stakeholders, we will think about the user groups, we'll think about the target groups. And then building on this solid foundation, this framework, I'm thinking about designing 3 big subcakes. So the themes are called technique, design, and experience. So technique stands for, some advanced technique, some low technique. The design stands for even a little design, even a little change in the design can change the whole thing. And experience is actually like the other component of my research is how to improve the user experience, how to improve the whole experience, not only user, but also the whole environment. And in the middle, it will call health intelligence. So health intelligence is actually standing in the middle of the 3 big circles. So changing from theme map, I'm thinking about a specific mind map. We cannot start with theme that's so broad and looks like an overview. We're trying to be specific, like what does technique exactly means? What I'm working on for technique is AI in health. I'm working on a lot of artificial intelligence in human in patients, also including like machine learning, natural language processing, or other advanced techniques. And my design is, how to design this kind of intelligent environment, how to design this specific features, how to design the specific experience. And that leads to the experience. Another specific mind map is the health metaverse. This is my ultimate goal for my research, is to build clinics in the metaverse settings. So starting from the mind map, I would like to introduce some of the work that I have already done before. As you can see in AI in Health, I'm talking about specifically like building an AI-infused biomedical literature-based clinical decision support tool, which we publish in Kai. And intelligent environment, we're specifically talking about like this features, this applications, like what I created, like an agriverse specifically for farm owners, for dairy farm owners, vital mask for emergency departments, physicians, and clinical professionals, and also HOPES, like a home opioid prescription education and smart storage program. And for the framework, I worked on several subtopics, such as HUG. So HUG is one of the companies that I started. This is a personal dietary supplement intelligent managed system, and we already got $6,000 funding from the specific research projects. And also, I'm working on the papers on the poster, which published in Harvard Grists on 2021, to bridge the patients and physicians gap by building this patient-oriented framework. And the last part is called AUTUMNs, which is the outcome-oriented techniques for users optimized model selections using visualization tools. And the last session, which is about the health metaverse, I'm working on a lot of like technology integrations in addressing the senior patient psychological needs for healthcare at home. This is a literature review, systematic review, and I'm building on a poster, which is Future Clinics in Metaverse and Hamlet Eye. So this is a mind map about what I'm actually already done or already are currently doing. And I'm excited to go through some very interesting projects. So we will start from there. So today our topic is about building this AI-infused clinical decision support system. So I would like to first identify the problem. So why we need to build this specific system and why we need to use AI, but not the other technique, right? Clinical decision support system already kind of exists. It's not an application, but it's already like a mindset for a lot of clinicians. They are making decisions, hundreds, billions of decisions daily. And the problem is how to calibrate the clinician's trust on the AI's explanation. So although clinicians are really familiar with this clinical decision-making process, allowing the clinicians to calibrate their trust in the AI suggestion is a very challenging goal. Among the other approaches, existing decision support system designs most often supported like the clinician AI trust calibration by explaining AI's inner workings behind their suggestions to make AI feel less like a black box. So it's more focused on this inner workings, like what's the back end? How do you generate? What is the algorithms? However, there's a problem is that this kind of clinical decision support systems move from the research labs to clinical practices, and this explanation approach struggled a lot. So that's why we attributed such challenges to the following three reasons here, the three boxes here. The first is that the AI explanations are not always available. Some clinical AI systems, such as the deep learning systems for medical imaging, are uninterpretable even to AI researchers, much more so to clinicians. The secondly is that in the clinical practice, clinicians make dozens, like what I mentioned, if not hundreds, like dozens of decisions in a day, while each AI informs a decision. It can seem kind of unrealistic to expect the clinicians to comprehend all this AI's inner workings in addition to providing enough carings for the patients. The third is that by nature, AI suggestions are not always intuitive or actionable to clinicians. In the fast-paced clinical practice, clinicians need actionable information that suggests a causal relationship with desired patient outcomes. ideally, this kind of causal relationship would be proven by randomized clinical trials on a large population. In contrast, the AI models make personalized, data-driven predictions. The validity and actionability of the AI suggestions are counterintuitive to many clinicians. So here are the three reasons that why we think this is an important problem and how we can employ this kind of AI-infused clinical decision support system to work on it. So as you can see that this clinical decision support system is not providing an equal sign like the calculator, but providing a cheat sheet. As you can see, there's a biomedical literature evidence list for generating the results from inputs to outputs. So as you can see in this image, there will be a clinical literature paper abstract, and we will use the GPT-3 and PubMed search engine to generate a one-sentence summary and a PICO table. So PICO stands for PICO, which is patient, intervention, comparator, and outcome. And on the right, you will see this post-design or post-study, I'll say, post-study prototype. So there are three big sections here, which are the patient basic information, AI predictions from a decision support tool, and a literature evidence. And the literature evidence is filtered out through the PICO elements. And after reading this prototype, it's kind of very useful. And our study also proved that learning from the patterns of the clinicians' use of the biomedical literature, which provides this shared ground of truth, we identify these design strategies for decision support system designs that can help clinicians more effectively examine this artificial intelligence suggestions. So the first thing I would like to point it out is that through this design of the decision support system, we learned by drawing on a biomedical literature, clinicians should stay focused on analyzing whether this is the right diagnosis or treatment for this patient, rather than around whether the suggestion is trustworthy by itself. So we're trying to give as much information as possible to the clinicians when they're trying to think about, when they're trying to come up or finalizing their decisions. Secondly, we learned that the clinicians value both rigor and applicability in their evidence. And we all know that rigor and applicability is not easy to present at the same hand. As such, we believe that it's critical and crucial to include a list of evidence that is varying levels of rigor and applicability. So you can see that's why we divide it into three sections. We have patient information, we have AI predictions, and we also have this list of biomedical literature. The third we found that we learned that clinicians save time by reading only the critical takeaway from every piece of evidence, rather than reading a particular pieces of evidence. So that's why you can see we use GPT-3, this kind of specific kind of chatbot function to summarize this very long and tedious the biomedical literature. And the decision support system might play a more critical role in calibrating clinician trust if it offered a comprehensive but succinct set of evidence and counter evidence. From what we talk about, we're trying to revealing some new design implications. So noteworthy, the biomedical literature and our prototype design represent merely only one source of external evidence that can validate AI suggestions and the one way of presenting it. Our design probes with the clinicians revealed that the additional opportunities in this newly open design space. So here are the three implications that we found because we interviewed the clinicians, requested forms of clinical evidence beyond text-based literature summaries. And then we also asked the multiple clinicians to suggest the literature evidence alone can be valuable for like low resource hospitals, such as rural health clinics, veterans hospitals. Well, some of these hospitals have only recently moved to deploying this electronic health records and may not have deployed the artificial intelligence-based decision support systems. this literature evidence can benefit the workforce who are likely to be less experienced and in a more significant shortage of physicians. So this is reasons, this whole little overview of why we're going to have this prototype and why we're having this clinical decision support system. And I'm going to move on to the Autumns. So Autumns is one of this project I work on for my master. This is the outcome-oriented techniques for users optimized model selections using visualization tools. So we know the users, when they're making decisions, especially thinking yourself as a patient, like my grandmother, she's already 80 years old. She is participating in this kind of decisions. It's very hard for her to choose or select one of the treatment option. So that's why I'm thinking about maybe we can using the visualization tools, which require less health literacy, but also increase this patient education and understanding of why we're choosing this specific outcome. So this is a computer science project, and I divided the frameworks into 3 parts. The first part is called the overview-oriented framework. So this is usually currently what clinicians or this healthcare settings are being used, is that they're providing a decision tree look-like framework. So that's why they're making this kind of decisions. However, I'm thinking about whether we can come from an outcome-oriented framework, which means that we can select from the outcome. That is to say, we're trying to reverse this decision tree from 1 to n, 1 to many to 1. It might be very hard to understand how do you do from many to 1, but what we want to say is that many is that we choose one of the default option from this many, and then we will just guide the users to select. So as you can see in this part, the outcome-oriented framework is actually choosing from the last part, and it will just go back to the final options. Through outcome-oriented framework, I'm also thinking about how to enhance the time efficiency, because if we choose from the many to 1 version, it may take a long time. So that's why I'm thinking about a stage-oriented framework. So the stage-oriented framework means that we will select the many options, which the outcome has many options. We're trying to categorize this many options into different groups. And then based on this user's preferences and demands that they will choose, we kind of categorize this many options or many outcomes into different groups. So we'll first let them choose, for example, in this framework, we put 3 options in one group. So they're going to choose one of the options from 3. And then if they're not satisfied, they're going to proceeding to the next group, and they're choosing that specific one treatment and compare with the other groups. So that actually saves a lot of time, because we already analyze through our users' preferences and demands, and that already helps us to save time, because we already know which group might matches this user's needs. So the third thing I'm going to talk about is the literature review that I mentioned for enhancing the patient experience. In this case, I specifically targeted at the community dwelling older adults. So these older adults, they're not in a nursing home, not in the hospitals, but they're staying at their home, but they still wanted to satisfy their psychological needs, which usually overlooked or ignored by a lot of cases. So this topic is called technology integrations to address the senior patient psychological needs for the healthcare at home. So this is an introduction picture that how patients access the healthcare professionals currently. As you can see, if the patient wants to approach the healthcare professionals, they're going through friends, similar patients, search engine, biased news, health insurance coverage, family members, clinical data, financial costs to the healthcare professionals. They go through so many different kind of stakeholders who are usually look at this group of stakeholders. They don't have a lot of background in healthcare, or they don't have sufficient health literacy. Therefore, they're receiving a lot of biased information or feelings. And the patient usually needs to satisfy 3 kinds of needs: physical needs, social needs, and psychological needs. But it's not satisfied through here. So therefore, I'm thinking about building up a systematic review, a literature review, to see why we need the technology integration in addressing the needs and how we can address in this kind of needs. Because the healthcare professionals, they just use a very limited of time to build up the consultation with the patients to deliver the illness, surgery results, treatment plans, costs, and this kind of unbalanced relationship between patient and healthcare professionals really make this patient experience as healthcare really bad. Even at home, it's even worse because they didn't approach to the real world healthcare professionals. They're not having this kind of services in person. Their experience might be worse. So this is one of this solution that I proposed. It's called a shared decision-making platform, Hamlet-I. Hamlet-I is actually an application that we're trying to guide the senior patients using some visualization techniques to help them select the best options. So I'm using the AUTUMS framework, the outcome-oriented framework, and also incorporating, involving this kind of needs from the patient's end, and we're trying to build a healthy relationships between patients and physicians, and at the same time we would like to improve the patient's health outcomes through communications, through this kind of 24/7 communications, and also through building up their decision quality. So as you can see, we first provide some basic information for the patients. So this application is specifically built for patients. And for the basic information, we will share the patient's specific daily healthy information. And then from there, we will ask them to customize their treatment plan. So here are the 5 factors that we're selecting, and we will let the customers to move the bar. After they choosing their imagined treatment plan, so they didn't see a treatment plan then, but they are going to imagine, like, for example, I already diagnosed this with cancer, this kind of very long-term disease. What kind of the time that I want to go to the hospital? You know, how is the pain degree? This is what I really care about, instead of knowing, you know, some very technical medical jargons or medical terms. So from there, after they customize their treatment plans, this Hamlet-I will present the options. So we'll present them 4 options based on their choices, and then they can choose which one matches their needs. Because we know that, you know, not everyone's preferences and demands can be satisfied, this kind of matching relationship can really make the patients to compare the pros and cons and help them to participate in this shared decision-making process. Because the patients are involved in the shared decision-making process, it's very easy for them to adhere to this treatment plan because they choose this instead of the physicians choose for them. And then we also, in this application, we have some other features to enhance their design, to enhance their experience. For example, you can see there's a kudo boards. We will have family members, especially in the COVID, like the pandemic era, people are very hard to meet their family members. So the family members could have this kind of kudo board to share the encouraging words or sentences to their family members. And we also have this emergency history. So the family members, they can keep track of the emergency, especially they're in a nursing home or in a hospital. So this application is one of the solutions to solve this kind of unbalanced relationship between patient and physicians. Therefore, it leads to my third map, the third mind map, which I talked about, the future health intelligence. So what do I think about the future health intelligence will be? I'm talking about the future is not the near 3 years. It's more like 10 years, 20 years later. What's our hospital will be? What kind of the services will we build? Will we deliver? Can we still satisfy their physical health needs while satisfying their social health and their like their mental health? So these are this kind of questions that really motivates me to think about how to build a health intelligence that's for future generations, for our parents, also maybe one day for us. So as you can see in this conceptual model, we're building a home-like pleasant experience. We are involving three big stakeholders. And in this case, you will see clinics, hybrid clinics, physicians, and patients. So in a healthcare journey, these are the three main stakeholders that will participate in the healthcare journey for a specific patient. So the blue bubbles represent the metaverse, represented a virtual space involving the three stakeholders. While the healthcare has a lot of in-person activities that's impossible to replace, we're trying to move some of this unnecessary in-person activities to virtual. So as you can see, we still have this kind of in-person visit, in-person diagnostic, treatment, in-person surgery, physical examination, also the clinic space, for example, like the emergency departments. But there will be some space that the clinics can provide, like a platform for holding the online physical meeting, physician meeting, virtual physician research, online distance surgery, especially like what I mentioned, we're talking about like the rural area, the military hospitals. And also it can do like the medication refill kind of alerts online, and also the virtual appointments, especially the emergency appointments, and the customized virtual health settings, also like the remote patient monitoring. The patients, they can involve in this virtual clinical metaverse through this family health records sharing, because the most important thing in the metaverse or in this kind of virtual place is the data. The data are transmitted easily. And also they can receiving the at-home rehabilitation through the metaverse, self-monitoring intelligent devices, while they still can stay at home, enjoy the home healthcare, and have this kind of at-home self-testing. So through this future health intelligent proposal, right now we didn't say it will be the future, but this is a proposing future, is that it's very possible for us to reduce the commuting time, and we can help to build this relationship closer instead of making it into a very separate three identities. And a lot of patients, they found it, especially in the other countries, very hard to approaching the physicians and clinicians because of the short staff problem, because of this resources problem. And we hope that metaverse could provide the equal access, also a better this countries or this people. So comparisons between the traditional clinics and the virtual clinics in metaverse, I just provides a kind of comparison here. As you can see, this current clinics or the conventional clinics, it provides the services like outpatient visits, appointments, meetings, rehabilitation, surgery, diagnostics, oncology, like exams, patient data. The in-person clinics for the virtual clinics in metaverse can be decentralized. So the clinics in metaverse and clinics in home and in-person clinics can divide into three. So as you can see, the clinics right now, they are very limited resources. But if we are expanding the clinics into in-person and virtual, it's actually expanding the resources, while at the same time, it's maintaining a very high quality. So the clinics in metaverse will have efficient appointment schedule system, customized virtual environment settings, patient-centered virtual rehabilitation, shared family history data, also better medical experience. And the clinics at home, they can just wear like a VR goggles, or they can use their mobile phones or intelligent devices to monitor their health and to provide like the at-home rehabilitation. While the in-person clinics still would have a lot of in-person healthcare activities. This is one of the posters that I made for 2022. This is a specific case study for an 82-year-old Caucasian man who is trying to access his doctor, but he lives alone and usually only sees his doctor for his annual physical exam. He has a good group of friends at a seniors club, and reviewed this chart indicates well-controlled hypertension and type 2 diabetes. This is some background that he had. And in traditional way that he needs to visit the clinics, and he will go to the in-person clinics and he will visit there, and doctor will provide some services or medications, and then he will be at home. However, he might need to revisit again, and there's a lot of problems with commuting, with short staff problem. He needs to wait six months later to revisit the doctors because of the lagging system. But what I'm proposing for the future clinics in metaverse is that it's possible that we can use this kind of virtual platform, and the patients, they don't need to go out to the hospitals. They just need to stay at home and have this kind of potential revisit at home. On the right, you will see a screenshot that I took from using the Meta goggles, the Oculus goggles, that I'm trying to see whether we can reach out to this very sequin VR space while looking at, with discussing with the physicians on some clinical decisions with diagnosis in a virtual place. And if I want to be private, sometimes I don't want to share the screen. I can just use this kind of avatar to discuss. And this is the proposal for the future clinics in metaverse. It does not necessary to be, it's not necessary to be one day in the future, but it could be possibly a way. And we're thinking about this way. It still has some problems like privacy problems. Also, the physicians have some doubts about involving artificial intelligence, but I think it could be a potential solution for the future healthcare journey. Okay, so I already took 30 minutes to talk about what's exactly I'm working and today's topic. I'm going through some of them. So right now I'm having some hands-on activities. And I already shared this hands-on activities sheet online. So let me know if you have a problem downloading it. Yes, thank you, Manogna. So I'm going through this hands-on sheet here. So we're incorporating ChatGPT. So if you want to participate in this hands-on activities, please make sure you are having this GPT open. It's okay if you're using GPT-3 or GPT-4, it does not matter. So we're trying to do some activities on building a clinician-centered clinical decision support system. And please brainstorm this idea and thoughts with me. So first, we will read a specific patient who called Sam Roberts clinical case. This is a fake data. This is a fake. I would say this is not fake data, but this is a data that made from a real world cases. And the task is that we are using ChatGPT, or if you have OpenAI, GPT-4, to generate a short patient case summary for clinicians, because they usually have very limited time to go through the case. And we will have, because clinicians are going to use this evidence to make the decisions. So we're going to generate a one-sentence summary from a list of biomedical literature. So today we will just have a very short version, only 3 papers, but we're going to label the PICO elements for each paper. So PICO, like what I mentioned, it stands for patient or population group, interventions, comparisons, and outcomes. So let's do it. So for this activity sheets, it's adapted from a demo site, a BLR demo sites, and also it's referenced from a full-length paper, harnessing biomedical literature to calibrate clinicians' trust in AI decision support systems. So if you're interested in reading more about how we are building the system, please refer back to this full-length paper. And also you can approach this very interesting hands-on activity through this demo site. I would like to make a disclaimer is that all the clinical information here is only for suggestions, and please don't think they are the actual cases. We're just guiding this process. So the blue box will show some instructions. Imagine you are a clinician assistant or a clinical librarian, and the patient Sam Roberts comes in with his referral PCP. Below is patient Sam's case descriptions from his PCP. PCP stands for the primary physician. The clinician is very busy that you are working with and doesn't have enough time to read the whole case description. So please generate a short description for the clinician to better understand Sam's basic information, symptoms, and other important information. So here you can see there's a case study. It's very long. It's adapted from a detailed records, and we will have some information here. So I'll give 1 to 2 minutes to read through it about the specific case, and we'll start from there. There will be some transcripts because he is actually coming to visits, and there's some discussion. Okay, so I think you already have a little understanding about this specific patient case. This is not a comprehensive patient case, but as you can see, even in a shorter version, it's already a lot of information to process. So it's very hard for clinicians to read through all this kind of records, and we also don't want the patients to reiterate about their symptoms, their problems again, because they're coming from a referral. That means they already talked with the PCP. So we'll go to ChatGPT, and I already copied this whole case. So I'm going to ask ChatGPT to generate a short paragraph summary for this patient case. Although GPT is a good resource, some of the information that from externally might not be correct. So we always focus on generating from a local file. So this is the reply from ChatGPT from a very long patient case study. As you can see, it says, Mr. Sam Roberts, an 82-year-old retired man who lives alone, came to see doctor because he hasn't been feeling like himself lately. He reports feeling sad, having trouble sleeping, feeling tired and slowing down, having difficulty concentrating, waking up early, and feeling anxious. He also feels guilty about his past divorce. He has mild, moderate depression, but does not endorse any suicidal thoughts. His chart indicates well-controlled hypertension and type 2 diabetes, and he has no substance use history. He also has some tremors, essential tremors, and mild pruritus. So from there, we generated this kind of ChatGPT short summary for a patient Sam, and we know his case right now. In a very short sentence summary, we know what happened for Mr. Sam Roberts. So this is the first step that we're asking the clinicians to understand the patient basic information. As I show in this in a prototype, that we have the patient information to look at. And then we were going to go to the DST recommendation, the decision support system recommendation. Okay, this is a possible answer. So based on the SAM's clinical description and some other health check data, an AI clinical prediction generates 4 predictions for patient SAM. So here is the AI clinical predictions. As you can see here, 4 treatment plans. And there are some prediction rates for the chances of remission. So you can see 81%, 76%, 69%, 79%. Some of them are really similar, like 81 and 79, but you can still comparing them. And we're still claiming that this AI clinical predictions are not replacing this actual clinical decisions. This is just a kind of recommendation. We're trying to see whether this is actually a recommendation and a possible solution, a potential recommendation. So therefore, we're going to the third part, which we are going to generate a list of evidence, a biomedical literature evidence that comes from this kind of peer-reviewed journal and well-established foundations. So for the third part, we have the literature evidence. Currently, I post 3 biomedical papers that related to Sam's symptoms and his case. And we're trying to use GPT here again to generate the paper's 1-sentence summary. So as you can see in this specific paper, for example, paper 1, paper ID 1, the paper name is a comparative review of escitalopram, medication E, medication P, and medication S, which is exactly comparing the three recommendations from the AI. And here we will post a paper link and the paper category, which is about the treatment comparisons. And we're going to ask you to generate a paper's one-sentence summary and the Pico elements that generated from this paper. So to make our work shorter, I'll first go to find out one paper here. So the first paper, I'm going to read it from PubMed. So this project, we're using PubMed search engine to analyze analyze what we're going to do. So this paper is from PubMed. So it's a very well-cited, peer-reviewed paper. And we're trying to helping the physician, the clinicians, when they're making decisions about which medications to choose. We're going to recommend them to read this paper. So we're going to use this abstract. I'm going to copy the abstract and put it in the ChatGPT. We're going to generate a one-sentence summary for the paper. Going to get the paper title for the paper and the abstract. So you can see that it generates a short one-sentence summary, but it acts as a takeaway alerts for the clinicians if they're going to comparing or if they are doubting whether the AI predictions are actually accurately fits the specific patient case. They can see from this literature evidence to compare. So the GPT said the paper compares 3 widely prescribed SSRIs, medication P, S, and E, and concludes that medication E is the first choice due to its combined efficacy and tolerability and its interaction with orthosteric and allosteric binding sites at the serotonin transporter. So this one-sentence summary can provide a takeaway for the paper, and it's really easy for the clinicians to process with the future papers. And we're going to generate a PICO table for it. So please generate a PICO table for this paper. So it generates a PICO table for us with population, or we talk to like the patient group is the individuals with depression. The intervention here stands for the treatments with medication E, P, or S, and the comparisons are for the efficacy and tolerability between the 3 drugs. And the outcomes is that medication E was found to be more effective and tolerable comparing to medication P and S, with evidence supporting that it's used as a first-line treatment for depression. So that's helping us, even like me without medical background or literacy, to understand this paper. And we may have some contradicting idea for the AI predictions, and evidence can provide us some, and we can have some evidence from the biomedical literatures to support this idea. I'm welcoming you to play around with 2 or 3 papers. Paper 2 is about the specific patient symptoms. So it's conducting a qualitative study for the patient expectations and experiences of an antidepressant therapy for the major depressive order. So we're specifically finding this paper for analyzing the patient symptom. So if a clinician is having a hard time deciding what specific problem it is, we are finding the evidence from biomedical literature. So this is an example, and I'm going to guide it here. So here's the possible answers for each paper. And as you can see, we select different perspectives. We select from this medication treatment comparison, and we select from the specific treatment, analyzation, and we select from the patient symptom. So it's very easy for us to get a one-sentence summary from this papers and also get a PICO, which is usually for perspective to understand a specific paper. So right now, we're still using the abstract to start because abstract may contain most information in a very short way. But if they're interested in knowing more information, they can refer back to the link. So they can link back to the paper itself. So this is actually an example for, okay, I'm going to case 4. This is actually the example of what I'm talking about, a one-sentence summary. They can just get some takeaway from the title and one-sentence summary. And if they click on the specific paper that they are interested in and would like to investigate more, they can see this P, I, C, and O. So they can see more information here. And if they're interested in seeing what specific problem about this paper, they can go to the link. So as a conclusion, I would like to say in the long term, my wedding cake research, while growing from 2D to 3D. So it's still built on a human-centered design framework. And as you can see, the AI in health, intelligent environment, and health metaverse will also grow through the time, right? Artificial intelligence in health is right now a very hot topic. Also, this accepted paper for Kai also talks about, the clinician AI interaction, the trust calibration, and also the intelligent environment is like the virtual environment, also the hybrid environment that we're all adapted to after the pandemic. And we're caring more about the experience in this kind of intelligent or virtual digital environment. And growing from the 3 solid cake, the future of health intelligence is actually being built, because we're trying to see whether it's possible to have, thinking about the theme, the technique, design, and experience, we can build a human-centered clinical system. So I'm proposing that the health intelligence will have 5 I-centered words, which stands for intelligent, inclusive, individual, interactive, and immersive. So these 5 I-centered words can build a solid foundation for the health intelligence. And these leads to the end of my session. Thank you so much. And again, thank you so much for the sponsors, for the schools and the departments and the companies, also the hospitals. Thank you so much. And I'm very open to the questions.
Perfect. Thank you so much, Yuexing. So we have several questions coming in. And
yes.
Let's start with this one. One audience member is wondering about the research that went into ensuring that elderly patients would be willing to use metaverse or sort of participate in virtual appointments, echoing back to earlier in your talk.
Yes, I would definitely like to answer this question. So right now we are partnered with several local community, retirement community, or this kind of organizations. And the older adults, especially the community dwelling older adults, they are really willing to take this kind of virtual appointment. And from my interviews, interestingly, a lot of the participants, the elder participants, they are adapted to the intelligent devices. They're using their computers, their PCs, or their children's computers or PCs to access their health records or access this kind of portal. So I think, although we still found out some senior people, there's some senior participants are not really willing to use this digital platform, or we say some very advanced work like metaverse to access their healthcare service, but they're kind of open to it, thinking about our parents' generation, because I'm talking about building healthcare for future. So it's for 10 years, 20 years later. Our parents are going through the healthcare journey. I think they're still pretty open to use their phone, because that's a common way right now for us to communicate, to access the healthcare. So thank you for the question. I think it's really good.
Yeah, absolutely. And folks can continue to enter questions into the Q&A. We always appreciate the engagement. Let's see, so another audience member asks, did GBT also identify the 3 evidence papers?
No, so the paper, the GPT-3 only identifies this summary. So let me be clear is that GPT-3 is still in a very abstract way. We're not trying to let GPT-3 to interfere the selection of evidence. So we're trying to use PubMed, and we're using the symptoms that the patient's having to get this related papers. So the paper selections are not done by GPT-3 or GPT.
Okay, good to know. All right, let's see. So one question I received asks, will this clinical decision tool specifically for the clinicians replace the actual doctor? Will the AI be responsible for the ultimate clinical choices?
This is a very good and also hard questions because we know AI right now develop in a very fast and sometimes immature way. And a lot of doctors or physicians that we're interviewed also have this kind of concerns that if they're proposing something or if they're making a decision and AI contradicted to it, a lot of patients might be biased to this kind of decisions. So I wanted to make it clear that my title is about clinical decision support tool. We're focusing on supporting the clinician's decisions. We're not providing, we're not directly providing these decisions, but we're helping to help clinicians to make the evidence-based decision in a shortly timed manner. And also at the same time, we're trying to make sure the information are clear, sharp, straightforward, and supporting the clinicians. Even they're making a decisions that's different from the AI predictions, we're still trying to make sure that the clinicians already know the evidence from this biomedical literature may be contradicting, but he or she has his own reason to make decisions. And we're kind of providing this context as much as possible.
Gotcha. Yeah, to just better inform the clinicians and make their jobs easier. That makes sense.
Exactly.
So this is a perfect segue to another question I received, which asks, which AI features or functions best address the clinician-related decision-making?
So I will say right now, so we actually conducted our survey way before ChatGPT actually going to public. So we concluded this study in last September, and at that time we were using OpenAI GPT-3. We're using this Python code to run instead of using their website to run it. So we're using this kind of AI features, which I talked about, like natural language processing, machine learning, to learn from this abstract, the short abstract, and try to extract as much information as possible to a short sentence summary. So this AI functions are actually providing a supporting role to generating the summary takeaways and helping to guide or helping to support the clinicians. But I'm happy to chat more about what specific AI features we're using.
Perfect, excellent answer. So I guess what I'm personally curious about too, do you envision these tools being used across multiple hospitals in the future? And if so, how does the difficulties around, say, like privacy between different medical institutions come into play with these tools?
Yes, privacy is a very important reason that actually slows down this the promotion or the spread of the AI tool, because every time when you insert in this kind of information, AI is learning from the decision-making process, and it claims that it has better decision-making skills than clinicians because it looks like it approaches more clinicians than more patients than a specific clinician. But that's actually not right, because each patient is a unique individual case, and we still wanted to involve clinicians in this decision-making process. So we're providing this supporting role, especially for, like I mentioned, this low resource hospitals or the rural hospitals that they cannot access this kind of up-to-date information, or they cannot access this kind of evidence, the literature evidence. We're using our tool to helping them to generating this list of evidence and providing them, also educating the clinicians to acknowledge what happened in the previous or current literatures.
Okay. All right, great. Let's see. So one anonymous attendee asks, for an undergraduate from a developing country who's interested in interdisciplinary research in AI and healthcare, what would you recommend as some areas of focus for an undergraduate thesis?
Yes, I love these questions because I don't have an undergrad thesis. I really like this. So I think one of the topic I can think about is I talk about my research is divided into 3 stages. The first stage is AI as an observer. So right now we are providing support, but you can ignore our support too. So I'm saying I'm an observer. If you want to involve me into the discussion, please feel free. AI is the tool. The second stage will AI become an organizer. It will organize the patient and clinicians to sit in the same table to make this shared decision-making process. So as you can see, Homlet I that is shared in the application are actually involving these 2 stakeholders to discuss and communicate more efficiently. So the last stage, I would say AI is providing like a space. It's an experience. AI is actually an experience maker. It's involving a metaverse. Metaverse is I would say a word, but we're trying to providing like a stage for the 3 stakeholders, the clinics or the healthcare facilities, hospitals, patients, physicians to be in the virtual space and to conduct this necessary healthcare journey. So this is the 3 stages. AI will still be a tool in this healthcare space. So don't make AI replace, this very decision maker, because we still need to talk about privacy, responsibility. Health is actually a kind of area it's impossible to ignore the significant negative consequences. Thank you for the questions.
Perfect. I'll keep handing you the big hard questions. So I apologize for that, but we
No
have
problem.
to go through them. So Julie asks and phrases it very well. What are the security and privacy implications of sending patient data to GPT?
Yes, this is a good question. So every time sending patient data, we have to remove the name, the specific, I will say any information that relates to a specific patient, not any information, it's any privacy information. For example, there is some patient ID or patient location or this kind of very sensitive information we will not be disclosed. But we're trying to give like a symptoms because GPT has a lot of resources about a specific symptoms and generating a summary. So we're trying to remove the sensitive data, but we just put our questions there. It's okay to ask questions, but it's not okay to kind of like sharing the privacy data. Yes.
Okay, gotcha. I see. Yeah, sort of taking the patient data away from the patient themselves. Yeah, and sort of treating them like an anonymous patient with a list of sort of symptoms and complications. Okay, great. So Alice asks a great question, and again, they're all hard but interesting. How do you incorporate different regulatory environments? For example, some states and insurance providers may have different recommendations for an appropriate course of treatment for a patient.
Very good question. This is actually a commercial kind of problem about our product if we're going to make it as a patent or a startup for helping people to make decisions. So I think we are trying to make sure our information is unbiased. That is to say, we're not like a Google searching engine that will put the advertisements at the first. All the predictions are generated in an unbiased way. And again, we're not providing advice for any specific case. We're providing support. They can choose to ignore, they can choose to accept. It's just like providing more context because the clinicians are sometimes hard to make decisions because they don't know whether there's any previous study about it or because they're making some different decisions that general populations are different from this specific patient. They also want to have some affirmation from the previous evidence. So we're trying to provide this context from an unbiased journal. That's why we choose the biomedical literature to provide this kind of very serious study, randomized control trials or the clinical trials, and try to use this foundational data instead of providing the advertisements, insurance companies, or the pharmacy companies.
Okay, yeah, that makes sense. So to the best of its ability, what would be provided for clinicians would be some kind of heavily peer-reviewed, unbiased answer, to whatever that means. But yeah, we're trying obviously to pick the something that's the least biased, and then I guess from there a clinician could then make judgment calls based on the specifics of, I don't know, sort of insurance information, which is a very real concern. Yeah. Okay, great.
Yeah.
Absolutely. So let's see, we're just at time. I was so engaged with all of these questions. So I believe, well, I'll let you sort of answer. Some folks are asking if they can contact you to ask additional questions. And so if you want to sort of specify your preferences in terms of like email or LinkedIn.
Yes, I will say LinkedIn would be the best way. Email, sometimes it goes to spam, but yes, please, email and LinkedIn should both work for me. But please forgive me if I have a very long delay because I'm actually at a conference.
Understood. All right. Well, thank you so much, Yuexing.